So what we discussed about the bronchial asthma? What are the drugs that are used in bronchial asthma? Anyone? Beta 2 agonist. Example of beta 2 agonist. Next person. Example of beta 2 agonist. Salbutamol is a short acting beta 2 agonist. Long acting beta 2 agonist. Salmeterol. Beta 2 agonist ছাড়া কি আছে? Any other drug, group of drug? Leukotriene antagonist. Example? Acha, next group of drug? Inhalational corticosteroid. Examples? Corticosteroids, inhalational can be used systemic, like oral and injectable. सबकोटा नामটা মনে রাখতে হবে, like inhalation it can be budesonide, cyclosinoid, and others are there. Beclomethasone. Among the oral is prednisone, prednisolone. Injectable, parenteral it can be hydrocortisone, methylprednisolone. Okay. Anticholinergics are there, long acting and short acting. सबकोटा पढ़ते হবে। পরীক্ষাতে কিন্তু enumerate drugs used in bronchial asthma very important. Beta 2 agonist topic is very important. Anticholinergics are important. Now, after covering all the drugs used in bronchial asthma, we are going for the treatment of bronchial asthma. Now, bronchial asthma, as per the recent guidelines, GINA guideline 2022, Global Initiative for Bronchial Asthma, the treatment has been divided into two tracks. One is track 1 and the other is track 2. When the patient comes with the symptoms suggestive of bronchial asthma, we have to confirm the diagnosis, we have to look for the modifiable risk factors, we have to control the symptom, we have to look for comorbidities, and then we should divide the patient into two groups. Either he will receive track 1 treatment or track 2 treatment. Now, who will prefer track 1 or track 2? It depends on the patient adherence to the long-term treatment. If the patient is not poorly adherent to the regular treatment protocols, then definitely track 1 is used. Otherwise, track 2 is preferred. Now, in both the tracks, the treatment has been divided into 5 steps as per the symptom of the patient. Now, coming to the track 1, steps 1 and 2 are common, where symptoms are less than 4 to 5 days a week. What can be the symptoms? It can be cough, it can be distress, it can be wheezing, and others. So, symptoms less than 4 to 5 days a week. In track 1, we go for basically as needed low dose inhalational corticosteroid with formoterol. Why only formoterol? Because we should know formoterol is a long acting beta 2 agonist having quick onset of action, having long duration of action. So, quick onset, so it can be used whenever the patient is having distress, like that of short acting beta 2 agonist. So, in steps 1 and 2, we are preferring low dose inhalational corticosteroid with formoterol, with formoterol. And in case of step 3, when symptoms are regular or the patient is waking up with the symptom of asthma in one day, at least 1 day per week. So, there are certain poor prognosis of asthma patient. Among them, one is waking up with the symptom of asthma, So, in those patients, step 3 treatment we will use, which is basically low dose maintenance inhalational corticosteroid with formoterol and reliever therapy as and when needed. Now, step 4 basically patient is having daily symptom, waking up with the symptom of asthma and low lung function. In them, basically we are using medium dose inhalational corticosteroid with formoterol along with reliever therapy as and when needed, which is ICS plus formoterol. In the step 5, which is the advanced case of bronchial asthma, we can add long-acting muscarinic antagonist in step 5. We have to refer the patient to the specialist. We should get the phenotype of the bronchial asthma done, and accordingly the newer treatment can be added, which can be IL-4 antagonist or IgE antagonist and others. Now coming to the track 2 treatment, again step 1 to step 5. Step 1 is symptom less than twice per month, where inhalational corticosteroid with SABA, short acting beta 2 agonist, as and when needed. In the step 2, where symptom is twice in a month or more, but less than 4 to 5 days per week. In those cases, low dose maintenance ICS is given. In step 3, basically 4 to 5 days per week থেকে বেশি থাকবে, but not daily. In those cases, basically low dose maintenance ICS with LABA. Coming to step 4, when there is daily symptoms, waking up with the symptom of asthma, medium dose ICS with LABA is given. And step 5, that the advanced case, we can add again LAMA. We can refer the patient to the specialist, get the phenotype done, and accordingly the newer treatment can be added. Now coming to the newer drugs of bronchial asthma. One is nitric oxide donors. What does nitric oxide do? Basically they are causing bronchodilation. So nitric oxide inhalation is useful in asthma as it relaxes airway smooth muscle. Now in upper airway it acts as the non-adrenergic, non-cholinergic neurotransmitter. Now there are certain nitric oxide donors that are being investigated for the treatment of severe asthma and pulmonary arterial hypertension. Number 2 is Benralizumab. Now comes the monoclonal antibodies that are being used or being tried in advanced cases of bronchial asthma. So one is Benralizumab, is the humanized IgG1 monoclonal antibody. It is the IL-5 receptor antagonist. It binds to IL-5 receptor expressed on the eosinophil and basophil. And what does it cause? It causes apoptosis by antigen dependent cell cytotoxicity. It is used as an add-on therapy in severe eosinophilic bronchial asthma. We have told that we can send the patient in advanced cases for the phenotype. One of the phenotype is basically eosinophilic asthma. So it is used as an add-on therapy in severe eosinophilic asthma in adolescents and adults, and is given subcutaneously. Headache, pharyngitis, fever and hypersensitivity reactions are some of the side effects. Tezepelumab is basically TSLP, thymic stromal lymphopoietin protein, is basically a IL-2 responsible for the chronic inflammation in asthma. Now it acts as a TSLP antagonist. It is a human monoclonal IgG antibody that inhibits TSLP and thus is reducing chronic inflammation. Again can be used as a maintenance therapy, add-on maintenance therapy in severe asthma. Mepolizumab basically is again a IL-5 receptor antagonist. It is a humanized IgG1 monoclonal antibody against IL-5, inhibit IL-5 binding to its receptor on the surface of eosinophil, used as an add-on therapy, add-on maintenance therapy in severe asthma with eosinophilic phenotype, and the other use is hypereosinophilic syndrome. Dupilumab is a monoclonal antibody that binds to IL-4 receptor, inhibit IL-4 and IL-13 signaling, used in eosinophilic phenotype or corticosteroid dependent asthma. Now coming to the status asthmaticus treatment, it is one of the questions asked in your exam. What do we mean by status asthmaticus? It is a severe acute exacerbation of bronchial asthma. It is called status asthmaticus. Now when the patient is seen to develop status asthmaticus, immediate hospitalization is required, and then moist oxygen can be given as per the oxygen status of the patient. If needed, non-invasive ventilation or the intermittent positive pressure ventilation can be given. Generally, most of the patients with status asthmaticus are dehydrated, so hydration should be maintained, and then the severe acidosis, if present, should be corrected. Suitable antimicrobial agent should be given, particularly if there is evidence of any infection. Now, coming to the specific treatment, we divide the patient into two groups. One is life-threatening case and the other is not life-threatening case. If the case is not life-threatening, we can give salbutamol nebulization every 15 minutes till the acute attack is over. And basically we may add oral steroid like prednisolone, or injectable steroid can be given as a bolus. Magnesium sulfate can be used 200 milligram or 2 gram IV over 20 minutes. So these are the treatment of status asthmaticus if the case is not life threatening. Now by mistaken it is written not life threatening, it should be life threatening. If there is life threatening attack of bronchial asthma, along with salbutamol nebulization we can add ipratropium bromide nebulization. Number one thing, we can give basically injectable steroid, corticosteroid bolus as well as maintenance dose, like injection hydrocortisone 200 milligram IV followed by 100 milligram 8 hourly. Again, along with the nebulization form, the short acting beta 2 agonist can be added intravenously or subcutaneously. Alternatively, aminophylline infusion can be given. Magnesium sulfate to be given 2 gram IV over 20 minutes. Even in those cases, if patient is not responding, general anesthetics like halothane is occasionally considered for treatment of status asthmaticus in selected case. So these were all about the bronchial asthma. Then coming to COPD. The basic difference in COPD and the bronchial asthma is the reversible chronic inflammation of airway mucosa basically, and COPD is irreversible. So it's an irreversible airway obstruction unlike bronchial asthma. So what the goal of therapy in COPD? We don't think of decreasing the inflammation. We think of relieving the symptom because it's an irreversible case. So clinical progress depends whether bronchitis predominates over asthma. Drugs relieve only symptoms without treating the underlying pathophysiology, and the goals of therapy are to lessen airway obstruction, that is the major goal, reduces respiratory symptom and improve quality of life. Again, preventing and treating the secondary complications like hypoxemia, secondary infection or cor pulmonale. Cor pulmonale means in advanced cases of obstructive airway disease like bronchial asthma, like COPD, the right side of the heart, that is right atrium and ventricle, get dilated, and the right ventricular failure may even precipitate. So that condition is basically called cor pulmonale, in the involvement of the heart due to the respiratory disease. Now treatment options for COPD, the very important thing is stop smoking, because smoking is a modifiable risk factor for COPD. So stop smoking. We can give certain vaccination to prevent complicated respiratory infection in COPD, particularly influenza vaccination and pneumococcal vaccination. So influenza and pneumococcal vaccine and proper judicious antibiotic therapy in COPD patient, because most of the patient will come with respiratory distress and we think it is basically due to infection, but it may not be due to infection, it may be due to acute exacerbation of COPD. So proper judicious use of antibiotic therapy. Long-acting muscarinic antibiotics are the drug of choice as bronchodilator in COPD, unlike in bronchial asthma where the bronchodilator drug of choice is beta 2 agonist, long-acting beta 2 agonist. ठीक है? Why? Because the parasympathetic tone in COPD is higher. So Long-acting muscarinic antagonists are considered most effective bronchodilator in COPD, unlike asthma where it is long-acting beta-2 agonist. Current guideline to treat a COPD patient. So current guidelines recommend combination of long-acting muscarinic antagonist and long-acting beta-2 agonist and add-on therapy with ICS as needed with short-acting beta-2 agonist as and when required. So basic treatment difference in COPD patient and in bronchial asthma patient is that in bronchial asthma patient we prefer inhalational corticosteroid is the first line therapy to decrease the inflammation. Inhalational corticosteroid, along with that we combine long-acting beta-2 agonist. But in case of COPD patient, the drug of choice is long-acting muscarinic antagonist. Along with that we add long-acting beta-2 agonist. We do not give inhalational corticosteroid as a first line therapy. Why? Because there are chance of increase of respiratory complications. So, and when the symptoms are not controlled with LABA and LAMA alone, then we add low dose inhalational corticosteroid. And short acting beta-2 agonist can be used as and when needed. Theophylline may be added orally. Revafenacin is a long-acting muscarinic antagonist, is a novel drug to produce a sustained long-acting bronchodilation with minimal anticholinergic side effects. Used via nebulizer for maintenance therapy of COPD. Systemic corticosteroids can be used orally if needed for a brief period in some patients. In advanced cases of COPD who are hypoxic, domiciliary oxygen therapy can be used in them. Use of mucolytics and expectorant are controversial. Now coming to the last topic, that is cough. Cough is a protective reflex. What does the cough do? When a patient accidentally takes the foreign body, basically the foreign body goes into the respiratory tract, then the patient cough to bring out that foreign body. So it's a protective reflex. Purpose is expulsion of respiratory secretion. In case of infection, the purpose of cough is to get off unwanted respiratory secretion. So purpose is expulsion of respiratory secretion or to get rid of foreign particles. Why does cough occurs? It occurs because of the stimulation of the mechano or chemoreceptors in the respiratory tract. The causes of cough are infective like viral, bacterial and fungal. It can be due to inflammation like in case of bronchial asthma. It can be seen in carcinoma, bronchogenic carcinoma. Cigarette smoking called smoker's cough. The drugs can also lead to the cough like ACE inhibitors. They are one of the side effects is cough like acetylcysteine, amiodarone, any inhaled medication like many of the metered dose inhalation or dry powder inhaler we use in patients of COPD bronchial asthma that may lead to cough. Iodine. Now cough can be of broadly two types. One is productive cough and the other is dry cough. Productive cough is useful. In productive cough basically the patient expectorates the sputum. So it is useful because it serves to drain the airway. And in productive cough, suppression of the cough is not desirable unless it is harmful to the patient, like in case of patient of heart disease. So in those cases, even a slight cough can be dangerous for the patient. Dry cough is basically useless, often troublesome, should be suppressed if it is distressing to the patient or if the consequence of persistent cough are serious. Now, drugs used in cough we can divide broadly into two groups. One is antitussives and the other is mucokinetics or expectorants. What do we mean by antitussive? Antitussive basically they decrease the sensation or tussle impulses in the throat and respiratory tract. They can act via central or they can act peripherally. And the other is expectorants, also called mucokinetics. They basically increase the respiratory secretion. Either they decrease the viscosity of the secretion or basically they increase the respiratory secretion. So these are called expectorants. Now centrally acting antitussives can be opioids like codeine, valcodeine, ethyl morphine, non-opioids like noscapine, dextromethorphan, clofenidanol and prenoxdiazine. Now opioid group of antitussives are basically not used nowadays because of abuse liability and respiratory depression complications. Peripherally acting antitussives are benzonatate. Benzonatate is both centrally and peripherally acting. It can be pharyngeal demulsions like lozenges, syrups, glycerin, licorice, steam inhalation, and lastly adjuvant, that is bronchodilator, salbutamol and terbutaline. Expectorants can be secretion enhancers like guaifenesin, potassium citrate, potassium iodide, ammonium chloride, tolu, valsam and vasaka. Now mucolytics, it includes bromhexine, ambroxol, carbocysteine and acetylcysteine. Among the expectorants, US FDA has only approved guaifenesin. Now antitussives, as said earlier, it acts in the central nervous system to raise the threshold of the cough center, or it can act peripherally in the respiratory tract to decrease the tussle impulse. It should be used only in dry cough. Mind it, antitussives, they are suppressing the cough. So it is used only in dry cough or if it is distressing to the patient or harmful. Now coming to opioid antitussives, morphine and its congeners are the best antitussive to be used. Problem is strong addicting liability and respiratory depression property. Now coming to the codeine, codeine more specifically act at the cough center. Abuse liability is low, but the major side effect is constipation. Respiratory depression and drowsiness can be seen at a higher dose, particularly in children. So it should be used cautiously in children. Contraindicated in asthmatics and in patients with decreased respiratory reserve. Basically, being an opioid group of drug, they can exacerbate asthma. Ethyl morphine is an antitussive respiratory depression property like that of codeine, but it is less constipating. And coming to the valcodeine, it is similar in efficacy to codeine but longer acting with no addiction or analgesic property. Coming to non-opioid antitussives, number one is noscapine, also called narcotine. It suppresses cough. Unlike codeine group of drugs, basically analgesic or dependence-inducing properties are not seen. Headache and nausea are occasional, can release histamine and exacerbate asthma. Dextromethorphan is a synthetic central NMDA receptor antagonist, does not depress mucociliary function of airway mucosa, does not cause constipation, although non-addicting. Some drug abusers indulge in the use of dextromethorphan. Dizziness, nausea, drowsiness, hallucination, ataxia may be seen. Clofenidanol is a central antitussive with weak antihistaminic anticholinergic property. Prenoxdiazine, it was developed in Hungary, desensitized the pulmonary stress receptor. Coming to pharyngeal demulsions, as the name suggests, it depresses cough which originate above the larynx in the pharynx. It has got a soothing effect, produce symptomatic relief, may be used as and when required, like lozenges, syrups, glycerin, licorice. Benzonatate is basically centrally as well as peripherally acting antitussives. In the central, it inhibits the afferent cough impulses, and peripherally it inhibits the pulmonary stress receptor. Structurally related to the local anesthetic tetracaine, mild anesthetic action as well. Steam inhalation is the most economical treatment, most convenient treatment and most safe treatment in cough. It is useful for cough originating below the larynx. And what does it cause steam? It causes liquefaction of the tenacious sputum so that cough can be brought out. Highly useful in bronchiectasis. Often some aromatic substances are added to the steam, but their use is doubtful. Steam inhalation being most economical and devoid of any side effect can be considered as the best expectorant, mucolytic or cough suppressant. Bronchodilators like salbutamol, terbutaline, they are adjuvant therapy. They reduce the cough due to bronchospasm, particularly useful in patients of bronchial asthma, asthmatic bronchitis or eosinophilic bronchitis. Mind it, all the fixed dose combinations available that contain multiple drugs for cough, in which one of them may be a bronchodilator, are irrational and should never be prescribed. অনেকটা cough products এর মধ্যে bronchodilator মেশানো থাকে, that use drugs should be avoided. To antihistaminics, many H1 antihistaminics, first generation basically, are used for the treatment of cough like dimenhydramine, diphenhydramine and others. How does it suppress the cough? Because of sedation and because of basically suppression of the cough center. They are used in dry cough, but they are used, it would be better to use suitable antitussive than the antihistaminic because of their sedation property. Sedative effect is not desirable and they dry up the bronchial secretion. Local anesthetics like lignocaine, they are used in intractable cough by nebulizer, as in case of bronchogenic carcinoma. Again, when we perform endoscopies, they are basically, the instrument is basically, they are on its surface, the local anesthetics are basically applied, so that the patient, while introducing the endoscopy through the mouth, the cough does not occur. So prevent cough during instrumentation like endoscopies. They are used as lozenges for intractable cough and painful acute sore throat. Hydration, again like steam inhalation, hydration is one of the most economical and useful therapy in cough. They maintain adequate hydration, reducing the viscosity of the bronchial mucus secretion, and it is recommended to take plenty of water in tenacious sputum, which is highly effective without any cost. Now coming to the expectorants, also called mucokinetics. Either they increase the bronchial secretion or they reduce the viscosity of the secretion. Mucolytics are especially useful in patients with tracheostomy, asthmatic bronchitis, cystic fibrosis. Now secretion enhancers, they include sodium and potassium citrate, act by salt action. Potassium iodide, problem is prolonged use affect thyroid function. Guaifenesin, Vasaka and Tolubalsam, they are the plant products. They enhance the increase the bronchial secretion and improves the mucociliary function while being secreted by tracheobronchial glands. Ammonium salt, they act reflexly, cause nauseating effect, increase the respiratory secretion. Bromhexine basically is a derivative of alkaloid vasicine obtained from the Adatoda vasica or Vasaka. What does they cause? They depolymerizes the mucopolysaccharides present in the sputum, and thus they are decreasing the viscosity. Particularly useful if mucus plugs are present. The problems are rhinorrhea, lacrimation, nausea, gastric irritation. Ambroxol is a metabolite of bromhexine having similar mucolytic action, uses and side effects. Acetylcysteine basically the opens disulfide bond in the mucopolysaccharides, in the mucoproteins present in sputum, and thus they are decreasing the viscosity of the sputum. They can be administered orally via inhalation in nebulized form, and they can also be administered intravenously. In intubated patient, thick sticky secretion can be liquefied by installation of acetylcysteine directly into the respiratory tract. একটা patient intubate হয়ে আছে, আমরা directly through the endotracheal tube acetylcysteine administer করতে পারি. The problem is gastric mucus barrier can be breached, so they should be cautiously used in peptic ulcer patient. nausea, vomiting, stomatitis and bronchospasm. Now, the other use of acetylcysteine other than cough is paracetamol toxicity. Paracetamol toxicity drug of choice ki ache? Acetylcysteine. Okay. Off-label use, dry eyes. They are decreasing. They are increasing the watering from the eye. Carbocysteine is one of the congener of the acetylcysteine, liquefied viscid sputum. In the same way, they are administered orally. They may break gastric mucosal barrier, so contraindicated in peptic ulcer patient. Gastric discomfort, rashes are the side effects.